Good afternoon, good evening, everybody. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. The COVID-19 pandemic changed our world, ushering in a new normal to which we are forced to adapt. The emergence of vaccines has now enabled us to look to the next normal in a post-pandemic future. What this normal will be like is up to us. If we can apply the lessons of COVID to shaping the next normal, we can build a future that is far healthier than our past. These events aim to inform a conversation that helps create this future. Thank you for being with us today, and a particular thank you to those who made today happen, Alicia Noel and Meredith Brown. Among the many disruptions the pandemic caused, one of the most acute was its effect on children. Health is created across the life course, and experiences early in life can have lasting effects. COVID-19 profoundly affected kids, interrupting their educations and creating challenges for their social development. Today, we will explore what the pandemic taught us about children's health and how these lessons can help us better support children's health in the future. We're delighted to have with us to moderate the discussion, Betsy Mckay. Ms. Mckay is a senior writer for the Wall Street Journal. She writes about US and global public health. Previously, she was Atlanta bureau chief, managing a team of reporters covering the Eastern US and several industries. As a reporter before that in Atlanta, she covered the beverage industry and public health. Ms. Mckay joined the Wall Street Journal in Moscow, where she wrote about Russia's post-Soviet political and economic transformation. And she's a member of the team of journal reporters awarded the 1999 Pulitzer Prize in International Reporting category for in-depth analytical coverage of the Russian financial crisis. She has won awards for stories in public health issues, including drug-resistant tuberculosis and maternity care in rural US. On a personal note, I always look for Betsy's columns and I always learn from them. It's really my great pleasure now to turn the event over to Betsy Mckay. Betsy, over to you.
Thank you, Dean Galea. It's very nice to be here, and I'm honored to moderate this panel. I would like to introduce the panelists. We have a very esteemed panel that we will hear from today. First, we'll hear from Dr. Rachel Garfield, who is Vice President at the Henry J. Kaiser Family Foundation and co-director for its program on Medicaid and the uninsured. She has 20 years of experience in Medicaid policy research and is an expert in data analysis on insurance coverage and access to care for the low-income population. Next, we will turn to Dr. Kevin B. Churchwell, President and CEO of Boston Children's Hospital. Since joining Boston Children's as its Executive Vice President of Health Affairs, Chief Operating Officer in 2013, Dr. Churchwell has been instrumental in leading the hospital's work to become a high reliability organization, one where zero avoidable harm impacts any patient, family member, or employee. Third, we'll hear from Dr. Nancy Lopez, who is a professor of sociology at the University of New Mexico. Dr. Lopez co-founded and directs the Institute for the Study of Race and Social Justice and is the founding coordinator of the New Mexico Statewide Race, Gender, Class Data Policy Consortium. Dr. Lopez currently serves as Associate Vice President for the Division of Equity and Inclusion. Next, we'll turn to Dr. Michael Liu, Dean of the UC Berkeley School of Public Health. Dr. Liu has decades of experience as a professor of public health, as well as obstetrics and gynecology, a proven track record of academic and national executive leadership, and a deep-rooted passion for health equity and social justice. Then we'll turn to Rashid Malik, who is the Director of Early Child Policy for the Center for American Progress. Mr. Malik's research has been featured in or cited by the New York Times, Vox, the Washington Post, and others. Prior to joining American Progress, Malik was a government affairs and communications associate for the Metropolitan Waterfront Alliance, an organization with the goal of making New York Harbor a shared, resilient, and accessible resource for all New Yorkers. And finally, we'll hear from Dr. Taranika Powell, an associate professor and vice chair for inclusion, diversity, anti-racism, and equity in the Department of Population, Family, and Reproductive Health at Johns Hopkins Bloomberg School of Public Health. She has expertise in adolescent health, qualitative methods, intervention development, and implementation science. Her research activities, publications, and funding history all demonstrate her commitment to improving the lives of vulnerable young people. So let's turn it over to Dr. Garfield.
Thank you so much. Let me just get my slides going. Can I get a thumbs up that things are working properly? Okay, great. So I am pleased to be here today. For those of you who may not be familiar with KFF, we are an independent healthcare research organization. We are not affiliated with Kaiser Permanente or Kaiser Industries in any way. So what we do is really provide data and analysis to inform current policy issues. So to that end, I'm going to do a bit of stage setting today and do a bit of a sprint / marathon through what we're seeing is happening with children's health and well-being during the pandemic. And I'm really going to take a broad view of what's been happening to children across the country, outside of the more than 7 million children who have themselves been infected with the virus, really taking a broader view. Now, when we first started looking at this issue back in the summer of 2020, which is the first time we tried to write a brief about what was happening to kids, there actually was not a lot of data available or information, and we ended up drawing on a fair number of international sources. So thankfully now we do have a fair amount of data and information about what's been happening to kids, but disturbingly, it's not a great story to tell. So let me go to the first slide here. So again, outside of tracking what's been happening with COVID cases, hospitalizations, et cetera, there hasn't been a ton of work looking specifically at kids' health outcomes nationwide. There have been some great focus studies that have come out, with the one exception of mental and social emotional health, and I'll talk about that more in a minute. But we have asked parents directly through our polling what is happening with their children. And you can see here, this is a poll that was conducted over the summer, that notable shares of parents are saying that their kids are experiencing some kind of negative health effect related to the pandemic. And these are new things that popped up during the pandemic and were not present before. So things ranging from difficulty concentrating to problems with sleeping and eating, to frequent headaches or stomach aches. These symptoms were more likely to be reported by lower income parents and also by Hispanic parents. And in the same survey, almost a third of parents reported that their child had experienced mental health or behavioral problems. I'm sure many people saw the Surgeon General's report that came out last week, which was essentially a call to arms to do something about poor mental health outcomes among children during the pandemic. And we are starting to see a fair amount of data showing that that is in fact happening. So you might expect that with all of this new demand and new problems that children are having, that there's been a commensurate increase in service use, and the system, maybe is rising up to meet those. Unfortunately, we're not necessarily seeing that happen. This is some data that the Census Bureau has been releasing through an experimental survey called the Household Pulse Survey. It's a great resource for what's happening during the pandemic. And you can see that a third of adults in a household with children in them say at least one child in that household has not had a checkup in the past year. And this is, if you look at other data sources from before the pandemic, this is an increase. There has been an increase in telehealth services to try to offset some of the service loss that we saw during the pandemic, but it has not fully offset that. And you see that across different analyses, using claims data, using surveys, et cetera. In fact, CMS has been releasing periodic data about what's been happening to utilization for children enrolled in Medicaid and CHIP. This has been a great source of information because that is a very large source of coverage, particularly for lower income populations. And you can see that in the period immediately following the onset of the pandemic, that's the dark blue bars, there was a substantial drop in visits across a range of services, everything from vaccinations, screening services, and very, very large drops in dental care and mental health care. Some of these services have bounced back a bit, although they're still down relative to where they were before the pandemic. But you can see there's still a large deficit in visits for dental and mental health. And this is despite the fact, by the way, that enrollment in Medicaid and CHIP has increased during this period. And again, that report does detail an increase in telehealth services, but not to the extent that it's offsetting what we're seeing in these declines. It's important to note that all of this is happening against a backdrop of a system that was not fully meeting the needs of everyone even before the pandemic. So here I'm showing some data from 2019 showing that there were many children, particularly children who were living in lower income families, who were not getting what I think many would consider a basic level of care, that is a regular checkup once a year, a regular dental visit once a year, or had some kind of unmet need for mental health services. Now, I want to turn briefly to another set of outcomes that we've been tracking during the pandemic, and that is the financial hardship that many families have faced. And these trickle directly into health because economic security is obviously an important social determinant of health and affects well-being overall. The pandemic had unprecedented job loss in a very short amount of time. One thing to bear in mind is that the economic downturn that happened was not uniform. And so there were big disparities in who was facing the burden of that, with people at the lower end of the spectrum really bearing the brunt of that. In addition, households that had children were particularly hard hit by the economic downturn. This data is looking at, even among families that had some kind of income or job loss, those who have children in the household are more likely to report some kind of financial hardship in meeting usual expenses, some kind of food insecurity or housing insecurity. Again, important drivers into child health. Another factor that I know some of our panelists are going to talk about in more detail that is really feeding into what's happening to children is what's happening with families. Because I think many people are not surprised to know that child health is family health. And again, we're seeing throughout the pandemic, parents and particularly mothers reporting extremely high rates of mental distress related to the pandemic. This data is from the summer. We have been tracking this at various points throughout the pandemic, and it has gone up and down a little bit, but the patterns really do remain. In addition, parents who were in a household where they had to have some kind of disruption to their work related to childcare are not surprisingly much more likely to report some kind of mental distress related to the pandemic. And that feeds back into all of the economic indicators that we've been tracking. Now, I think it's important to bear in mind that these effects are not uniform across all children, obviously. And I've tried to give a glimpse into some of the demographic breakouts as I've gone through the slides, and I have limited time today. But I did want to take 30 seconds to just highlight a few groups that are particularly at high risk during the pandemic. A lot of these also came up in the Surgeon General's report. So for example, and by the way, this list is of course not exhaustive. There are other groups that are probably in need of some targeted attention. There are about 14 million children in the US who have what's called a special health care need. So they have an ongoing health, developmental, or mental health problem and may have some serious disruptions in services. There are millions and millions of children who rely on schools to access their healthcare services or for early diagnosis or early intervention of those services. And they may have faced a delay in the diagnosis of those services, particularly last year when many schools were remote or hybrid. There's been some attention to what's happened to the child welfare system with reporting down during the pandemic, but a lot of people, I think, in agreement that that does not mean that child abuse and is down. In fact, that there may be a problem with mandatory reporters not having as much contact with children. As you've seen in some of the slides I've presented or some of the points I've made, children in lower income families or children of color are much more likely to be in a household that has experienced financial stress or parent distress. And then importantly, children who were facing mental health challenges before the pandemic are particularly at high risk. I want to wrap up by just talking very, very quickly about vaccines, because that's where so much attention is right now. This is from a survey we did just in November. The report came out last week, and it really shows a range of parent perspectives on vaccines. But one thing I think is important to take away as we're going into trying to get everyone vaccinated so we can get into the new normal, is that a lot of parents are expressing concern about vaccines for children, and saying that they either need more information or feel that there is not enough information about vaccines, or have serious concerns about side effects for their children. So there is still a need to overcome misinformation about what the vaccines are doing for children and how safe they are. In addition, in this poll, parents raised a number of logistical questions or concerns about getting vaccinated. Things like not being able to get time off of work, not knowing where to go, not being able to travel there. So while I know there's a bit of a sigh of relief that vaccines are now available for many, many children, there's still a lot of work to do to that end. So I will stop there and turn it over to the rest of the panel.
Thank you so much. And now we'll turn to Dr. Churchwell.
Thank you. It's a pleasure to be here. I'm going to try to share my screen. Great. So what I'd like to do is just in the next few minutes, just talk a little bit more about what we're seeing from the pediatric hospital standpoint in this next new normal. This is just a list of things I just wanted to cover, including COVID in pediatric healthcare, a little bit more about the behavioral crisis we're seeing in pediatrics, the role and what we're seeing in health equity, diversity, inclusion in our children. And then I try to end on a bit of a positive note about the future of healthcare. So the point I want to make in this slide is that although we're talking about a next normal or the emerging from COVID, the reality is we're not really emerging, that I would describe it. We're still in it, as I like to tell our folks at Boston Children's Hospital. What I mean by that is that this pandemic continues to evolve. With the mutations of the virus and its presentations, we continue to have to deal with the next asset or the next issue associated with this COVID virus. In children, there are a couple of things. One, children do get infected. Because of their health, they do not present for the most part to the hospital in critical condition. And that's been the case throughout this 20 months. It's important to note there was a period of time, especially in the August and in the early fall, where a section of the nation had an increase the number of children presenting to the hospital with COVID critically ill due to the issues of chronic illness, obesity, et cetera, other conditions these children had. But for the most part, especially in the Northeast, that has not been the case. And so for our standpoint, what we have seen is actually a condition that occurs 2 weeks after a asymptomatic COVID infection. And that's something that we've called a multi-inflammatory system condition. Inflammation due to the COVID infection, delayed response, immunologic response, a response that looks a great deal like another disease that is called Kawasaki's disease that affects the vasculature. We figured out how to care for children with this problem, and we continue to see it at some level. And of course, then there is the long-term effects of COVID that we continue to follow. And so that's the infection that we're seeing, and that's continued to evolve. I will tell you that one of the things that we're learning is that we were not ready. We are not ready for a pandemic associated with the infection itself in children. And that's something that we've got to work on as we move forward. The bottom of the slide just shows an example of what's happening with emergency room visits in children. As you can see at the beginning of the slide, early on, there was a significant drop in visits, but slowly these visits have continued to increase, and they've changed in terms of their caricature. Specifically, we see more and more children with behavioral health issues coming to our emergency department. And I'd like to talk a little bit more about that in the next slide. Before I go there, I just also want to mention another aspect of COVID that should be recognized is what's happening to the caregiver. And that as in these 20 months, there's continued decrease in the number of staff that we've been able to utilize. The great resignation is occurring, especially in our nursing environment. And it's something that we've got to deal with moving forward. So one of the big issues that we're seeing is the behavioral health issue that was mentioned in the previous talk. Prior to COVID, we saw this happening, and that there was an increase in the number of our children presenting with behavioral health issues due to stress, due to social issues, the social network, the internet, or whatever, however you want to describe it. But with COVID, this has been what we described as turbocharged in the number of children presenting. Usually in our facility, at our hospital, we were very much stressed when we had upwards of 20 to 25 children per day presenting with behavioral health issues, whether it's to our emergency department or our regular floor or to our inpatient psychiatric unit. In COVID, that number has risen dramatically. Today, it was the number of 70. When you get to 70 children with this type of problem, you don't have a plan to deal with them. You just have to deal with it from an hour-to-hour basis. The issues associated with this include the historic stigma related to behavioral health issues and the lack and the insufficient investment in services and research. The other issues are the shortage of integrated behavioral health care services, again, driven by lack of funding. This was always being ignored, and now it's presenting itself with problems that we've got to address. We've also seen the racial and ethnic and geographic and socioeconomic disparities associated with the behavioral health issues. And it's driving us home that these are issues we've got to really deal with from a holistic standpoint. The other issue that we have seen, of course, is the issue around equity, diversity, inclusivity that's presented itself over the last 20 months. Certainly associated with the issues and the death of George Floyd and Breonna Taylor. But in part and parcel, this pandemic has really shown that this is a major problem, especially in our children. Our work, especially in the Children's Hospital, is to provide and show there are opportunities with equity, diversity, inclusivity in solutions. The work to be a more inclusive environment that doesn't tolerate any form of racism or bias. We're working to recruit and develop a more diverse workforce. Our goal is to look like the patients and the families that we take care of. We believe that there's excellence in care in that piece of work. We also recognize that many of our institutions have been around for more than 100 years. So there are a lot of policies and procedures. Embedded in those are issues of structural racism that we have to root out. And you can see there are multiple opportunities in terms of equity and diversity that this pandemic has brought to the forefront and that we have to work through to lead, to make a difference. So I want to stop my piece of the talk by presenting what I've presented in terms of some of the issues, but also some of the opportunities from a positive standpoint. And so that what COVID-19, especially in the pediatric environment, has taught us. One is that the adoption of artificial intelligence has been really important. It has really driven the opportunity to make that part of the care that we provide and improve care in the pediatric space. It's done work in terms of the predictive analytics that we're using, clinical decision support, collaboration with specialists. And there's opportunity there as we move forward. I will tell you that the adoption is really going to be based upon the belief that there's a consistency in care that can be provided with artificial intelligence, or what we call here at Boston Children's Hospital, aligned intelligence. And that's a piece of work that I believe will continue to have to be developed. There's also work that, from a positive standpoint, that has been developed with the COVID-19 pandemic, and that's around digital innovation care. We've had to be forced to improve access to care. When at our hospital, we actually sent 2/3 of our staff home to provide remote care in an immediate period of time, over a week, in that we had to revert to and utilize telemedicine. Telepsychiatry being a great example of that actually improved access to care for our children. But this is a piece of work that will continue to evolve. And there are barriers to it, barriers that are internal, barriers in the technology that will be figured out, but also external barriers in terms of how payers, in terms of how the public is viewing it. In order for that to really work, I believe there has to be an improvement in the partnership to care. What we've recognized is that the internet or the web is not just something that some individuals or some groups have, especially neighborhoods of color. where the access to the internet is not the same than others. What that really means is that those neighborhoods, those families, those children don't have access to care. So we believe that there has to be a different viewpoint, a different evolution of that, meaning that really broadband or the web access should be treated like a utility. You get your electricity, you get your telephone, you should get broadband. And in doing that, that's going to change the paradigm. That's truly going to access the opportunity for care, to reduce the access and the barriers. I'd like to just end by just talking about the other opportunities. There are always opportunities as we evolve and potentially as we emerge from this pandemic. And that's in the research and clinical innovation in pediatrics. There's still ongoing work that will make a difference. Work in stem cell therapy, work in gene therapy. We're at the cusp of developing a cure for sickle cell disease using gene therapy. The next evolution of that is how do we make that a therapy that can be utilized across all different aspects, no matter what the cost is, and reduce the costs and make it a therapy that can be utilized across the globe. But there are opportunities that I believe we will continue to access and develop as we move forward, as we move next out of this next new normal. So I'll stop there and turn it back to Betsy.
Thank you very much, Dr. Churchwell. These past two presentations have been fascinating. So let's go now to Dr. Nancy Lopez.
Gracias. Thank you, familia. I'll focus my comments on the urgency of employing intersectionality as a lens, as a framework for our equity work. I'd like you to consider the following questions. What is your street race or perceived race if you were out in public? What about your gender? What about your class origin? And specifically, I want you to think about parental educational attainment when you were 16, when you were in high school, whether that was in the US or abroad. What about your ethnicity or cultural heritage? Think about why it's important not to conflate that with race. What about your citizenship status, sexuality, and do you identify as a person with a disability? And think about how an intersectionality lens pays attention to the simultaneity of all of these social locations as influencing your social determinants of health and that of youth, especially now during the pandemic. A quote from sociologists Maxime Bakazin and Ruth Zambrana in a 2019 article in Gender and Society explain the power of intersectionality. And I quote, "We caution that Latino-Latina as a social construct must be problematized, that it's complicated by differences in national origin, race, class, ethnicity, and by the confluence of these factors. An intersectional approach acknowledges these differences and seeks to reveal and understand how they shape experience. When we use the term Latina, it is not as a unitary term that homogenizes distinctive groups, but as a term of implicit solidarity," end quote. I want you to think about that because often we talk about Latinos as a brown monolith, and that might impede our equity lifts, right? Now I want to talk about two empirical studies that show the urgency and power of intersectionality. A 2021 study by Feldman and Bassett, published in JAMA, finds that while it's true that men in general die at higher rates than women, the 2020 cumulative mortality rate for COVID-19 was lower for white men than it was for women who are Black, Indigenous, Alaska Native, Latina, or Pacifica. The age-adjusted rate for white men with a high school degree was the same as the rate for college-educated Black, Indigenous, Latino men. The rate was even higher for Pacific Islander men. What are the structural origins for this that would place people of color at higher risk for COVID exposure? Crowded housing, we know, occupational and para-occupational risk, than whites at the same level of education. This illustrates why an intersectional lens is paramount. Another example comes from my article, co-authored and published in the Race, Ethnicity, and Education Journal. There we looked at 6-year graduation, a college graduation rate over a 9-year period at a public university in the Southwest. And when we examined the odds of graduating when compared to high-income white women, we find that low-income white, Asian, Black, and Hispanic women and Indigenous women had odds of graduating that went from a low of 14% less likely to 40% less likely. It should be clear that reporting odds of graduating or any outcome, whether it's health or education, is by race alone, gender alone, or class alone is insufficient for equity use. We need to really pay attention to the structural drivers of that: settler colonialism, anti-Blackness, and structural racism. Next, I want to turn to potential policy solutions. And this refers to work that I'm currently doing with funding from the WT Grant Foundation and Hewlett, looking at the role of ethnic studies and really reducing inequalities for all youth, but particularly those that are marginalized. In a 2021 study published in the Proceedings of the National Academy of Sciences, my colleagues Bonilla, D, and Penner find that 9th grade ethnic studies classes reduce not only academic inequalities, but also those socio-emotional inequalities that we see in terms of outcomes. What's most promising is that they found that these reductions in inequality were enduring and long-lasting. In our own research on ethnic studies in the Southwest, our preliminary findings suggest that part of the mechanisms that are contributing to these reductions in inequality is countering all of the controlling and negative images of our communities and centering the community wealth, the funds of knowledge, and creating a space for critical interrogation and solutions of these structural inequalities. California just instituted a statewide ethnic studies requirement for all high school students. Imagine if this were extended to preschool, through middle school, through higher ed. In my book, Hopeful Girls, Troubled Boys, Race and Gender Disparity in Urban Ed, I found similar dynamics, that it was these kinds of courses, spaces in K-12 that created empowerment, critical thinking, and long-term reductions in inequality. And finally, I want to share with you the importance of transforming our administrative data collection to employ an intersectional lens. And this is part of a new study that I'm working on with funding from the Robert Wood Johnson Foundation. And I want you to think critically about the importance of not only just disaggregating data, but also engaging in intersectional inquiry and praxis. For example, if you ask someone's race or ethnic origin in one question, and the person says, I'm Hispanic, I'm Latino, I'm Cuban, I'm Puerto Rican, Colombian, or Dominican like myself, and stop there, assuming that we all occupy the same street race, you may miss an opportunity to find out if someone who identifies as Hispanic and is light-skinned and street race white is treated differently than their siblings who might be seen as street race brown, Black, Asian, etc., even if they're the siblings biologically related. In 2018, I wrote an essay for theconversation.com, over 71,000 readers, entitled The Census Bureau Keeps Confusing Race and Ethnicity. And there I talk about those of us who are interested in understanding everyday racism need to ask not only about your personal identity, but how others racialize you. My co-authored article published in 2019 in the Sociology of Race and Ethnicity, and also in 2019 in Critical Public Health, was based on a national survey of health outcomes for over 1,400 Latinos from multiple ethnic backgrounds, both immigrant like my parent or US born like myself. And we find that when we use that street race measure in conjunction with intersectional analysis that considers the simultaneity of race, gender, and educational attainment, we make visible inequities that would otherwise remain invisible, specifically in our findings on mental health. So if we're just relying on self-identified race, we might miss an opportunity to make inequities visible and actionable. And finally, where do we go from here? I make 3 recommendations for improving children's well-being through what Collins and Bilge call intersectionality as inquiry and praxis. First, transform all of our administrative data collection and analysis. It's always important to include those 2 questions. How do you identify, mark all that apply, but what's your street race? Mark only one that most represents how you are racialized in a particular area. And that we must also add parental educational attainment as another axis of inequality that we seldom collect. We collect gender generally, but we seldom ask that one. Second, institutionalized ethnic studies from preschool through grad school. Think about the strategies for partnering with advocates and community members. The preponderance of research shows that these types of courses, content, and pedagogy that is honoring and centering community wealth is empowering and reduces socio-emotional and academic inequities for families and generations to come. And finally, build relationships across sectors to cultivate a community of practice around intersectional inquiry and practice, a consortium of sorts. I invite child advocates, lead statisticians, youth, and families, cultivate discussions about the difference between disaggregated data and intersectional analysis. They're not the same thing. And ask who benefits from the status quo of data collection, who remains invisible, and what knowledge can we gain through intersectional praxis? Thank you.
Thank you very much, Dr. Lopez. And now next up is Dr. Michael Liu.
Yeah, thank you, Betsy. And I want to thank Sandra and Meredith for inviting me. Such a great honor to be on the panel with people whose work I've admired for a very long time. It's great fun to be on a panel called The Next Normal, which challenges to rethink and reimagine the future of children's health. The title of this series reminds me of an essay by the novelist Arundhati Roy. So I'm just going to read a passage from it. Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It's a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us, or we can walk through it lightly, with little luggage, ready to imagine another world and ready to fight for it. The pandemic is forcing us to rethink and reimagine children's health in this country. Given what you heard about the crisis in children's health in this country, rushing back to normality, doing more of the same, would be exactly the wrong thing to do. Those of us who truly care about children's health need to be bolder, more imaginative, and more transformative, ready to reimagine another world, a world where every child, no matter where they're from, or the family they're born into, or the color of their skin, have a fair shot at reaching their fullest potential, and ready to fight for that world. But how are we going to get there? Since I only have 8 minutes, I'm going to take a page from Sandra's Think, Teach, and Do, and I'll summarize my key points in 3 words: earlier, deeper, and upstream. That is, if we wanted to get to a new normal in children's health, if we truly want to improve children's health and advance health equity in this country, there are 3 things that we have to do. We have to intervene earlier in the life course and across generations. We have to dig deeper into the root causes of child health disparities, and we have to go upstream to tackle the political determinants of children's health. So first, we have to intervene early. If there's one thing that we've learned from the pandemic, is that when it comes to prevention, there's so many things that we do in this country, we do too little too late. We did too little too late to prevent the spread of the pandemic. We're doing too little too late to prevent chronic diseases. And when it comes to children's health, we're doing too little too late. So for example, if we want to prevent preterm birth, which is a major driver of infant mortality and the leading cause of racial ethnic disparities in infant mortality, that we don't start when a woman comes in 3 centimeter dilated. That's going to be too late. Even prenatal care may be too little too late. And that's because we got a growing body of science which suggests that what happened to a woman throughout her life course, including when she was just a baby inside her mother's womb, could influence her future reproductive outcomes. And that's why if we want to prevent preterm birth, if we want to close the racial gap in infant mortality and children's health, it's too little too late to stop preterm labor when the woman comes in 3 centimeter dilated. It's also too little too late to try and cram all the good things to less than 9 months of prenatal care We gotta start caring for women, not only when she becomes pregnant as she were just a reproductive vessel, but when she was just a baby inside her mother's womb, an infant and toddler, and a child, an adolescent, and young adult. And we have to do more than just healthcare, right? Because we all know that healthcare contributes only 15–20% of health. Health has a lot more to do with the earth that we breathe, the water we drink, the food we eat, and the social conditions in which we live, grow, play, and learn. So we gotta create the social conditions in which girls and women can be healthy across the life course. Second, if we want to get to the next normal in children's health, we have to dig a lot deeper into the root causes of why in the richest country on earth, large groups of children are systematically locked out of a fair shot to reach their fullest potential. We're not going to improve children's health simply by improving children's health services. We're going to have to tackle root causes such as institutionalized racism, which is a root cause of much of the health disparities that we see in this country. But how are we going to do that? Well, over the last 30 years, I've gone around the country, gone to places like Ferguson and Flint and Baltimore, working with communities to try to help them address the high rates of maternal and infant mortality. And when you go into the community meetings, when you really listen to community voices, you come to realize pretty quickly that what truly drives the high rates of maternal and infant mortality in those communities is the institutionalized racism that's manifested in differential access, not only to healthcare, but housing, jobs, education, opportunities across the life course. And yet, because most of us who are trained in medicine and public health aren't trained to take on institutionalized racism, so we go back to doing the easy stuff, like enhanced prenatal care or care coordination, which is like putting a Band-Aid on the problem. But I truly believe we're not going to advance health equity and children's health in this country without fighting social injustices, without dismantling institutionalized racism, which, by the way, is also really important for us educators to think about, that we have to make sure that the next generation of medical and public health professionals are trained in not only the core public health and medical sciences, but also trained in the knowledge, the tools, and skills to take on racist policies, practice, and institutions in the healthcare system, in public health system, in community, and in our nation. And finally, if we want to get to the next normal in children's health, we have to go upstream. For too long, we in maternal and child health toiled downstream to ameliorate the harms that are caused by decisions made upstream. And as much as we like to think that we can fix all MCH problems with MCH services and programs, advancing health equity will require us to go upstream to take on political determinants of health. Let's not forget that the biggest gains in children's health in the last 150 years have come from the passage of child labor law and women's suffrage, regulation of food and environmental safety, and overall improvement in educational attainment, economic opportunities, and social status of girls and women in our society and around the world. But somewhere along the way, we kind of lost our way. We became too medicalized. We became too technocratic. Not that it needs to be an either or, but I truly believe that the biggest gain in this country in children's health in the coming decades will come from solving the climate crisis, protecting reproductive rights, reducing social inequality, and ensuring social conditions in which all children and families can be healthy and thriving across their life course. So how are we going to get to the next normal in children's health? Not by staying downstream, by going upstream from the White House to every state house, from the halls of Congress to every city hall, from corporate war room to every federal forum. Let's make sure we show up wherever and whenever consequential decisions are being made that impact on women and children's health. That's how we're going to get to the next normal. And that's how we're going to take this country just a little bit closer to that vision of America that I think that we all still believe in, a country where every child, no matter where they're from, the family they're born into, where the color of their skin, have a fair shot at reaching their fullest potential. Thank you.
Thank you very much, Dr. Liu. And now our next presentation is from Rashid Malik.
Thank you, Betsy. Briefly, just to talk about the Center for American Progress, to note that we are a multi-issue think tank. We work on everything from LGBTQI issues to economic policy and tax policy, health policy, of course, and for the last 8 years now, early childhood policy. In the past few years, we have been mostly focused on childcare and early childhood education, but we are doing a lot of cross-cutting work on healthy early childhood development. For the purposes of this discussion, I'm actually going to focus on childcare and what the COVID-19 pandemic has done to our childcare system, to the families and the children who rely on it. Let me pull up our presentation. Right. So when we're talking about the COVID-19 pandemic here, we first need to understand that there were tremendous inequities in childcare quality, access, and availability. Before we had this crisis, we have a system that is reliant on private tuition and parents being able to mostly pay for pay into the childcare system, which left most programs really struggling to get by when they had to close early on, and as enrollment has failed to return to normal over the past 18 months. But even though childcare is very expensive in most cases, and for most families, early educators really have not been making much money. There's not a lot of profit in this industry, and the hundreds of thousands, millions of early educators that have been the backbone of our childcare system really been stressed and overworked, and I would argue undervalued, even as we've celebrated them and their work and their importance during the COVID pandemic. We've lost a lot of them to better job options and to the fact that it is really hard to raise one's own family on the wages that are associated with early childhood education. And then finally, I'm going to get into this in a little bit more detail, but I think one thing that we'll be studying and trying to understand for years and years and decades even is the effect of the isolation and the learning loss that we will undoubtedly uncover in those cohorts of young children who just didn't have as much interaction with their peers, didn't have that serve in return in those nurturing experiences with trained early educators, and on such a massive scale, and amidst so many other stressors and issues related to the pandemic. Let's get to the next slide. So briefly, I want to touch on my work in studying disparities in access to or proximity to childcare, licensed childcare options. Because of the kind of market failure of the childcare system, what we have is a severe undersupply of licensed care options. And here I've pasted in a map of just the greater Los Angeles area. You can go to childcaredeserts.org and type in any zip code, address, city, county, whatever it is, and actually see how these disparities in proximity and access really strongly correspond to higher levels of education and higher median family incomes, as you might expect. This is has for years and years meant that a lot of parents have had to make sacrifices or patch together whatever care they could. We know that, of course, consistency of caregiving is crucial to a child's learning and their healthy development. And a lot of kids from low-income families have to go between a lot of different caregivers, often a family member, very frequently a grandparent, but also nearby neighbors, friends. Sometimes this results, often this results in parents having to cut back on the number of hours they work, or often mom not being able to remain in the workforce, which puts really financial pressures on families who really often, almost always need two incomes to get by. And this is to say nothing about how difficult it is to raise young children as a single parent. But moving on to the pandemic, early on in, if we think back to March and April of 2020, a lot of the country really completely shut down, and most childcare programs did have to completely close. Some of them were called into duty to help care for the medical staff and frontline pandemic workers who heroically were serving serving the needs of patients and had no childcare options for their kids. But it was immediately apparent that the childcare industry was going to go right on, could potentially go under without some kind of sort of rescue package. In March of 2020, the National Association for the Education of Young Children surveyed their members, and 30% of providers said that they didn't think they could survive a closure of more than 2 weeks. Unfortunately, many of them did have to close for longer than that. I think it's important to remember that childcare in the United States is a network of hundreds of thousands of small businesses, mostly women-owned and operated small businesses and nonprofits, which made it really hard for them to access the Paycheck Protection Program. The Bipartisan Policy Center found that fewer than 6% of childcare businesses took part in the PPP, and this was not matched with a sizable enough early response in terms of that early pandemic legislative investment and spending that was in the CARES Act. So you can see on the right side of your screen, there was $3.5 billion in there for the childcare industry. That was just a fraction of what Delta Airlines on their own received in order to get through the pandemic, through the early months of the pandemic. And when this CIRSA, which I won't attempt to disentangle the acronym there, was passed in late December of 2020, which provided $10 billion, mostly for to extend childcare subsidies to more families. Unfortunately, we did have in March the American Rescue Plan Act sending out or appropriating $40 billion for the childcare industry. But it might, I don't want to say it was certainly not too little, but we worry that it might have been too late to bring us back to what the kind of childcare sector that we had prior to the pandemic. We have kind of plateaued in the number of staff in early childhood education. We're still down more than 10% from where we were in February of 2020. And the childcare industry has had severe problems staffing back up and trying to enroll children. The median pay for an early childhood educator is, in many places about $12, $13 an hour. It pays better to go work at Starbucks or Costco or Amazon or a whole lot of other jobs that will offer benefits in addition to better wages and better hours and lower levels of stress to one's own family. But I want to point out that this has had a real effect on enrollment in early childhood education centers. This is from a paper by Elizabeth Cassio at Dartmouth, just released as a working paper in October, and uses data from cell phone location pings, actually, to try and isolate changes in visits to childcare centers. As we can see, a nearly 60% drop from in the early days of the pandemic, and it really has plateaued, and further data actually extending more into 2021 shows that we've plateaued in terms of our enrollment, which makes sense as it is a direct function of staffing and staffing capacity. Finally, I want to point out that hopefully we've got some glimmers of hope in terms of this really extraordinary investment that has been proposed in Congress in the form of the Build Back Better Act. This would invest nearly $400 billion into our early childhood education system, and I think is crucially important, since without it, we're facing a decimated and fractured and shattered childcare system. And these are as Dr. Garfield mentioned, these are stresses on families. When you talk about childcare disruptions, this is crucial to families' economic security, and of course, children are always learning, and a part of healthy development involves hopefully quality, enriching experiences in early learning environments. So with that, I'm going to hand it back to Betsy. Thank you.
Thank you so much. That's some of those data are so disturbing, particularly about the difficulties in getting in employment and getting early childhood educators. So hope for the future. Finally, we'll hear from Dr. Powell, and then we'll go to questions.
Oh, we can't hear you, Dr. Powell.
Dr. Powell?
Yep, that's like the phrase of the pandemic, you're on mute. Hi, everyone. So I am, like a lot of my work has been community engaged work. So I wanted to actually take this time to talk a little bit about some of the work that we've been doing in partnerships with libraries. And just pose like libraries as partners for public health, child and family health during the next normal. I really also wanted to make sure that folks, if you think about, I hope that this like conjures memories, if any of you are lovers of libraries like I am, not only to really think about libraries, it's not just a personal space, but also a professional space. So I am always going to send out acknowledgements in case people's eyes glaze over by the end. I just always want to thank the folks. You see me, but this is a huge team effort of all the things that we've been working on. So first of all, let's talk a little bit about libraries, right? So there are nearly 17,000 public library branches in the US, and that does not even include school libraries. If you count school libraries, they're actually over 119,000. And this public library, there are about 9,000 systems across the country. And they serve more than 95% of the population. So we've been talking about child health, but earlier, my panelists, other panelists have talked about child health being family health. So if you think about like libraries can serve the wide range of the population across ages. And they're also located in lots of different types of neighborhoods, right? So not just like, this isn't one of those resources that are just in some neighborhoods, but not in other neighborhoods. They're everywhere. They're in low income, low resource, and high resource, and in rural communities when often their other services are not there. And if you think about the spaces and like the where we are now in the country, like libraries are still considered one of the places that is safe, a place that is safe and welcoming and with low barriers to entry. if you think about libraries, like you don't have to pay to go there. You can stay there for a while. You can sit. No one will bother you if you've been there too long. So like, as we think about like how might we partner with libraries to think about address some of the public health issues that we're dealing with now, especially as it relates to young people. So libraries as public health supporters isn't new. It may just be new to us, right? So I've on the next couple of slides, I kind of talk about some of the efforts that have already been happening across the country. So here where I am in Baltimore, Maryland, opioid addiction has hit us much earlier than it did the rest of the country. So many of our librarians are already stocking and being trained to administer naloxone. We also have a social worker and library and the lawyer in the library services at our libraries. In Greensboro, North Carolina, there are folks who partners with libraries to address food justice and develop physical fitness programs for adults and families. In Charleston, South Carolina, there's a program called Women in the Southeast. And this is also a partnership between libraries and the health system to offer high quality health care to women in rural areas. And this was in response to women asking for a safe and private space where they can receive health services when they can't get to the hospital. In Chicago, they where my hometown, they've actually the Northwestern has actually partnered with the Chicago Public Library to create digital tools to increase awareness of and participation in research. So to help people understand like what's being asked, what's the purpose, why would I ever want to be a part of something? And I think as we're thinking about health and wellness, like along these streams are also like researcher along all those continuum. So that's even before COVID. So let's think about now that we've been in a world where COVID exists, like libraries continue to step up. So in Bucyrus, Ohio, this is a little town in Ohio. If anybody from Ohio here, you may know it. They were the first library system in the state of Ohio to partner with the health department to distribute at-home COVID tests. And then Pottsboro, Texas, another small town, they were offering telemedicine and patient navigation services to increase access, again, for rural and elderly residents. If you think about like who might have not only like all parts of the family, if you think about multi-generational families, folks are really struggling to figure out how to do the things that they normally do when they were isolated in their homes. And so the libraries were stepping up. Once the vaccine became available, the folks in Prince George's County, Maryland, they created a vaccine hunter hotline to help people receive vaccines as quickly as possible. Over the course of 150 days, they made about 12,000 calls to people and like connected people to services to find out where they could get a vaccine. And in Cleveland, Dr. Churchwell talked about this earlier about internet access being a barrier and really a determinant of health. Cleveland, they've expanded their services to not only just offer hotspots, but they've increased their stock from 600 to 900 with the hopes of getting to 1,200, and so that they can not only offer more, but increase the rental time for the hotspot so that we can have that, so that more people can access broadband services. So moving forward, what does this look like? So I think that there are three big things that I'd like to propose that how libraries can continue to be partners in the next normal. So the first is to offer public health trainings. So my team and I, during COVID, just in May, we fielded a national survey of library staff. And just asking what kind of training I'm an adolescent health professional by training. And so we had read about all of these efforts that have been happening with adults and the elderly. We're like, well, what's happening with young people? Is there the same interest or excitement to work with young people and address issues? Well, the word on the street is yeah. So we had about 300 responses from library staff across the country from 37 states. And almost over 90% said that they had received a training on at least one public health topic. And we listed a range of topics on which they could have talked about. I have here some of the most comfortable topics they were discussing with adolescents are sexual and reproductive health, substance use, and infectious diseases. And infectious diseases included COVID. So this really may be an opportunity for us to build our workforce or people who are able to talk to families and youth about the COVID virus, about the COVID vaccine, if we are able to offer them the training that they need to feel comfortable. Interestingly enough, the least comfortable topics they were discussing were around violence and race and racism. Again, thinking about what Dr. Lopez said earlier, we can't shy away from these topics. And I think the more that we're able to educate all sectors of our community, and because library staff are dealing with folks of all races across the country, and really being able to help them understand how to have these conversations and feel comfortable with them may enhance our efforts as well. And so I think that secondly, libraries can be host sites for interventions for vulnerable youth. We all have probably read or heard about the Surgeon General report for the kids are not all okay, and thinking about helping librarians offer trauma-informed coping strategies for youth. So right now here in Baltimore, we are one of the first cities to, we have a Healing Cities Act that was enacted in 2020. And it mandates that all city officials are trained in trauma-informed strategies. And so the first set of city employees who are being trained are our librarians. And so they're being trained in both mindfulness and restorative practices to be able to not only better relate to each other, but also with their patrons. So trauma-informed trainings. Above, we saw that many librarians are comfortable discussing sexual health and substance use. So why not host interventions there or in partnership with library? Earlier, we heard also that there's been academic loss and the needs of children with special healthcare needs may need additional support. So they can also host academic-oriented interventions. And then finally, we can extend our health and telehealth services for families that already exist. Dr. Garfield talked about the well child visits and mental health visits that were missed. Maybe this is an opportunity for us to work with libraries who have computers or tablets that are available and have the capacity to be able to be a space when people can't quite make it to the hospital, but they can get to their local library to be able to offer some of these services. In our city and other cities, libraries have also been sites for COVID testing and vaccinations. How do we extend those efforts so that folks in communities, they don't have to go to a one big place, but most cities have many libraries, and we might be able to build on that resource. And then finally, thinking about the connections to food and housing services, as Dr. Garfield talked about earlier, that this isn't just a physical health thing. There's so many other determinants that COVID has, so many challenges that COVID has given to families that we really need to think about. How do we build onto the assets that we already have in the communities to be able to support families and young people? So here are my big three takeaway messages. I think that partnering with libraries, public libraries, will extend our public health efforts. And I'll admit, this was a new thing to me. I've worked with churches and schools, and it wasn't until recently, and I was learned about all of these things that the public libraries are already doing. So why not, again, extend our efforts by partnering with them to help them do their job as best as they want. Libraries really are public health assets that have already been and can continue to provide services to youth and families in the next normal. And libraries are willing and ready to support youth and families. I think that is the most critical thing, right? We're always wondering, do people want to do it? Yeah, many of them do. And I think that like any of us doing something new, we want to make sure we feel trained and comfortable doing it. And with that, I will wrap. So feel free to continue this conversation with me on email, I'm on the web, Instagram, Twitter, all of the things, and thinking about the opportunities that we have in partnering with libraries and other community-based assets to support child and family health in the next normal.
Thank you so much, Dr. Powell, and thank you all. These are all really fascinating presentations. We have just a few minutes for questions. So I'm going to start with one that I had myself, but that someone has also written in to ask, which is about the behavioral health issues that children have, that have been created by the pandemic and are sort of emerging from the pandemic. So what is the role of our viewer asks, what is the role of the education system or the responsibility of the education system in addressing that? I might broaden it a little more to ask, if what is the role of the education system and what are the role of other entities in addressing that, and what do we need to do? We probably only have, I want to open it up to the panel. We probably only have time for a couple of responses, but who has some thoughts on how to address this?
Or one issue, this is Kevin Churchwell, one issue that we believe is important is that the educational system doesn't have the primary responsibility from this standpoint, in that we believe that there needs to be a continuum created. Our children have a primary care pediatrician. Our children have the educational system, the school system. They also have families and community programs, along with the healthcare system writ large. And it's we believe the solution lies in creating that continuum of communication and development of resources and support that all of us need, but specifically the educational system needs, that we need to feed into the educational system that support structure to help our children.
And if
Okay.
I could just add, I mentioned that there is a role for curriculum in terms of promoting well-being and empowerment and mitigating the social determinants of health. And I mentioned specifically the extensive research on the impact of ethnic studies content and pedagogy and community-driven solutions as one way. So I think that there is a space. It is clear that educators are not health providers. That's not what we're talking about. But what we're talking about is the role of empowering curriculum and promoting community well-being and individual student well-being.
Thank you all. I had one question that I just want to throw out to everybody, but for a quick sort of lightning round answer, which is, when you look to the long term now, who knows when we'll come out of this pandemic, but say 5 years from now, what is one impact on children that you think we're going to be dealing with and that you're concerned about, that we will be dealing with 5 years from now? Dr. Lopez, why don't we start with you? Just a quick right off the top of your head, what concerns you most?
This really complicated political climate that is trying to erase the importance of looking at structural inequities, whether that's race, gender, class. So one thing that we will be dealing with, I think, is the erasure of history in our textbooks and in our curriculum. So that is concerning to me.
Okay. How about Rachel Garfield?
I hate to sound like a broken record, but I do think the focus and bringing to light issues in child mental health and longstanding disparities in access to services is an opportunity. I'm hopeful that people are finally really talking about this, not just as like a stigmatized group of children who have perhaps a serious disorder, but really, using phrases like resiliency and how to teach resiliency in schools and how to really embrace the fact that children's behavioral health needs to be part of the healthcare system and part of children's wellness overall.
Okay, thank you. And how about Michael Liu? Do you have a thought, like your one thing 5 years from now you think we'll be worried about most?
Yeah, distrust of science, distrust of public health, cynicism about the political process and civic community.
We're dealing with those now. Yes, great. No, good thoughts.
May I add to Dr. Liu? So that
Yes, I was going to call on you next. So perfect timing.
Well, it goes on because one of my biggest concerns, in the next 5 years is like empathy, right? Like this is a time when everyone needs to get on the same page and we're not. And so I wonder how our kids will interpret that in 5 years. Like if someday we do get on board, we don't I'm concerned that the way that we're responding as adults now will impact the way our kids see helping each other. So the civic engagement or the duties that we as a country, as a people have to each other to support each other. So that maybe it's empathy, maybe it's something else, but I worry about that a lot. I was like, we're being examples, and I don't know if we're being the best always. And so, right. And so like our kids are watching. And as a parent, I really felt you, Dr. Malik, like the childcare, I felt that deeply. I have a toddler and a teen. So I think about what they get from me and all the people around them. And I do in 5 years, I wonder how our children will interpret this time and how we responded.
So we need to be the adults in the room, basically. How about Rashid Malik and then Kevin Churchwell? I'd love to hear your thoughts.
Yeah, I worry that as we have for decades and even centuries, that we will quickly unlearn the lessons of the pandemic with regard to caregiving, early childhood education, that we all, we've heard so much, we've learned so much about how important those relationships are and how important those experiences are for children. But my fear is if we don't solve this problem, if we don't deal with it, if we don't put our money and our resources where our mouth is, then we're going to just return to a system that relies on the low wages and the hard work of women, especially women of color, who have cared for and educated our children for decades without much acknowledgement or appreciation. So I hope I'm wrong there.
Yeah, it's a huge issue. I hope you're wrong too, and I'm glad you raised the point. And finally, Dr. Churchwell, what do you think we're going to be, the biggest impact coming out of this 5 years from now?
Well, I worry about the time loss for our kids in terms of their development, their socialization. Children are very adaptable, and that's something that we need to rely on. But we need to pay really close attention to this time lost and how can we help them catch up.
Great. Thank you all so much. Do we have time for one more question? If we do, we have a very specific question I thought I would throw out. I think this one is also for Dr. Churchwell, but others jump in. So one viewer says, as a parent of a 4-year-old who's immunocompromised with sickle cell disease, who was unable to start school this year, what can I do to best support her when she does start kindergarten next fall, especially concerning social skills, health, safety, and potential anxiety?
Well, I think your question really describes your next steps, is to ask those questions, is to get with your healthcare provider, your child's healthcare provider, and create a plan for your child. Starting that plan now, I think would be really important, but also support your child as they move forward and start school.
Anyone else want to chime in on that one?
Yeah, I'd like to echo Dr. Churchwell and really talking to your primary physician about like the benefits, the costs and benefits of getting the COVID vaccine, right? Like that right now is our best protection of staying safe, both like adults and children. And so she's 4 now. I have a 4-year-old. I feel you too. Like thinking about like when they turn 5, like what will this look like and what will this mean for them? Because they will be in a school with other folks.
Yeah. Anyone else? It's such a I know how difficult it's been for children to go back, and in some cases, some talk about re-socializing, and it's such a strange word to hear. Certainly. What about vaccination concerns? I mean, how do you think that parents have? We heard from Rachel Garfield about how many questions parents have. What is, clearly something needs to be done to reach them more effectively. What are some better ways that could be done and get more kids vaccinated more quickly?
Well, one of the things that we found is to meet them where they are, to try to really understand what their concerns are and not to preach to them, but to understand what the potential cultural concerns are, what their social concerns are, what their health concerns are, and to provide that information to them in a way that they can appreciate, understand, and be with them not just once, but be with them through the process. We have found by doing that, by becoming their partner, we can get many, if not most families to the point that have concerns to get them to understand the importance of vaccination and to get their kids vaccinated.
Great, thank you. We have another question here. This might be from Rashid Malik. If BBB passes, will it be in a public school locale? What will be the metrics whether childcare ranges from custodial to high quality academic services like Head Start and all places in between?
Yeah, what the structure of the Build Back Better is to use our existing network of childcare providers and to have a mixed delivery system. And so that's going to mean including and welcoming in home-based childcare providers, center-based childcare, school-based childcare. You know, you can imagine, one of the things I love studying and learning about is outdoor preschools. You know, there's a whole variety of learning environments that are welcomed to be a part of this system. It will require a state to federal partnership, but it has in it 3 years for states to develop their plans as they ramp up participation and enrollment in the program. And states really need to develop a tiered quality system so that we're putting public dollars towards incentivizing increases in quality. And that's in terms of both the facilities and the structural elements of quality, but also those process elements of quality of paying teachers more, hiring more teachers, giving them more opportunities for professional development and support, lowering the stress that they feel and just allowing them to do their job. We have turnover rates of 30 to 40 to sometimes even 50% in early childhood education programs in a lot of states. And it's unfortunate we lose so many really talented, dedicated early educators every year just due to the low pay. So that's a big piece of it, but it also, you know, has requires you know, some thoughtful development of preschool curricula, and also a consideration of what we think quality is. And that does not necessarily have, you know, that really should, as a last final point, take into considerations, you know, differences in cultural views of what early childhood education is, and understanding the comfort level that parents have, and honoring that choice that parents are making, and bringing the parents into this policy-making process, in fact, so that we have, you know, we can meet families where they are and bring as many families into a quality early childhood environment as possible.
Great. So I think we're out of time. Thank you all for the great questions, and thank you to the panelists for the great presentations. I'm going to turn it over to Dean Sandro Galea.
Well, first of all, thank you that was a phenomenal panel. It's really was incredible. I was sitting here and listening, and really just hoping we had many more hours to ask questions for everybody. So thank you to everybody for being a part of it. Thank you to Betsy for excellent moderation. You know, perhaps I'll end by echoing what Dr. Powell said. When Dr. Powell said, well, the children are watching, and they're watching what we do at this moment. And I find that very affecting. And I think it really speaks to the fact that what we need to do at this moment is learn from the challenges of the moment, learn from COVID, so that we don't make the same mistakes again. And you know, nothing redeems the tragedy of COVID. Nothing redeems 800,000 people dying in the country, but it certainly would be furthering the tragedy if we do not learn from the moment. So insofar as gatherings like this, having scholars on a panel like this, the work that you all do, the work you've shared with us, and the audience who's participated in this helps move us forward, help us learn. Hopefully we are doing the right thing by the moment. So everybody, thank you for spending time with us. Thank you to the panelists, thank you to the moderator, and thank you to everybody in the